Yeah. Good evening, everyone. Hello from India. Good evening, my friends in Africa and in the Indian Ocean continents. So I am Dr. Vivek, and I'm really thankful to Dr. Karthik Gopal sir for making an eye-opening presentation on the COVID-19. And I pray for everyone's safety in Africa and all over the world. I will be talking on the radiological evaluation of hepatobiliary system. In case I am not clearly audible or I am too fast, please make a comment and I will accordingly change my presentation. So coming to the evaluation of the hepatobiliary system, the radiological evaluation. The hepatobiliary system is an important part of the digestive system and
Vivek.
It consists of the liver, gallbladder and the biliary tree. So here on this slide, we have got the modalities and the pathologies listed over here. The common ones are the plain radiography, ultrasound scan, CT scan, MRI scan and MRCP. And advanced imaging methods are scintigraphy and hepatic angiography. So I will be basically talking on the radiography, ultrasound, CT and MRI features. Coming to the pathologies, there are pathologies grouped under congenital, infectious diseases, metabolic diseases, vascular etiologies, and tumors and masses. So coming to congenital abnormalities of the liver cyst is the commonest entity. The remaining are listed over here. I will be talking more on the liver cyst. The liver cyst on ultrasound is a common feature, and almost everyone who is practicing ultrasound would have seen many cases of liver cysts. On ultrasound, a liver cyst is a completely benign lesion, so it contains fluid of water consistency. It will be showing a thin, imperceptible wall, and it will show posterior acoustic enhancement. There will be no vascularity within the cyst, but there can be vascularity towards the periphery, but this is not always true. Coming to the CT scan features, on contrast CT, a liver cyst will show the similar findings as seen on the ultrasound. What we see on the CT is a rounded or globular lesion with water that is from 0 to 10. And there will be no internal enhancement, and it will be well demarcated and well circumscribed. This is again clarified and confirmed on MRI scan, where we see a complete hypointense water signal intensity on T1, and the exactly opposite, very much hyperintense, well circumscribed lesion on T2. And as you can see from both the images, series of images, the cyst size may differ, whereas this is a small to medium cyst, this is a giant cyst. Coming to infectious diseases of the liver. Infectious diseases of the liver may be grouped under hepatitis, and hepatitis can be due to many causes like viral, bacterial, fungal, and also there are infections of parasitic origin like amoebiasis and hydatitis disease and so forth. Talking about acute hepatitis, this is mostly caused by viral organisms, that is hepatitis A, B, and C. In acute hepatitis, what we are seeing here is the ultrasound picture showing a starry sky appearance, which is multiple tiny white spots all over the liver. This is a hallmark sign, and once you have seen this on a patient, then you are sure shot ready to make a diagnosis of acute hepatitis and call for liver function tests. Alternatively, we can also see indirect signs of acute hepatitis during ultrasound, which includes a thickening of the gallbladder and edema around the gallbladder area. On CT, the imaging findings of acute hepatitis includes edema around the periportal area, and this is an indirect sign of inflammation. Further, on MRI scan also, we replicate the similar findings, as you can see in this image. Coming to the next group, that is the hepatic abscess. An abscess is usually of infective origin, we have got multiple hundreds and millions of bacteria multiplying and causing damage to the tissue, in this case, the liver. So what we see, initially, a liver abscess is usually iso to hyperechoic, and this is, again, fairly well circumscribed, but sometimes it can be also irregular. In some patients, you can see more than one abscess. So in more than one hepatic abscess can be seen. Then what we see is the various stages of a hepatic abscess. If there is continuous and non-treated hepatic abscess, it may go in for pus formation and there will be an anechoic collection within the cyst, within the abscess. So what we do then is that we call for drainage of the abscess using a long needle. I regularly do this around 2 to 3 cases a week, or we put a pigtail catheter if the pus is too thick and we cannot drain it out using a long needle. So here what we see is the liver abscess on the CT scan. On the CT scan, the liver abscess is seen as a peripherally irregular, well circumscribed lesion with central non-enhancement. There might be peripheral edema in the surrounding liver. On MRI scan again, we see similar findings of a well circumscribed T2 hyperintense centrally occupied lesion and then peripheral edema. Coming to metabolic disorders of the liver, I will be touching on fatty liver, which is the commonest, and cirrhosis of the liver. Coming to fatty liver, all of us have seen fatty liver day in and day out. There are cases where sometimes one radiologist gives a fatty liver, the other radiologist differs. So we have to be a bit clear on making a diagnosis of a fatty liver. So I will be telling you the basic pearls of diagnosing a fatty liver, which will help you to certainly confirm a fatty liver and to grade accordingly to satisfy the clinician as well as the patient. Coming to fatty liver, on ultrasound, we know that fat is bright. So a fatty liver will be brighter than the rest of the liver. Brighter than the normal liver. So what happens is that the liver echo texture increases and it is more than that of the kidney and the spleen. And in grade 1 fatty liver, it is only that the liver increases in brightness. The portal venous walls and the diaphragm are well seen. In grade 2 fatty liver, the portal venous walls are obliterated and the liver is brighter, but the diaphragm lining is well visualized. In grade 3 fatty liver, even the diaphragmatic lining is obliterated and the deeper portions of the liver are difficult to appreciate. So that is grade 3 fatty liver. Coming to fatty liver on CT, since we know that fat is lucent on CT, so we expect the liver to be hypoattenuating on CT. And in general, I usually keep a HU value of anywhere less than 40 as absolute HU value of less than 40 as a fatty liver. Coming to MRI, a fatty liver on MRI is confirmed by using a technique known as in-phase and out-of-phase. In this technique, we do an in-phase scanning and out-of-phase scanning. Those who are doing MRI scanning will be knowing about it. And in the out-of-phase scanning, there is a signal drop from the in-phase scanning, which is more than half of the signal drop. And that signifies up to 15 to 20% of fatty liver in most cases. Then coming to cirrhosis of the liver. Cirrhosis of the liver is an end-stage disease and is a chronic liver parenchymal disease. It can be due to alcoholic liver disease or it can be due to viral hepatitis and is an important diagnosis to be made to further manage the patient clinically. In cirrhosis, the liver, actually what happens is that it becomes more fibrous and more scar tissue is formed and it loses its elasticity. So here what we see is the coarseness of the liver and there may be nodules. Nodules may be less than 3 mm, micronodules, around more than 3 mm, a few centimeters, that is macronodules, or more than 5 centimeters, which are giant nodules. Then coming to different types of nodules, histologically, we can come across regenerative nodules, dysplastic nodules, siderotic nodules which contain iron, and rarely we can also come across a hiding hepatocellular carcinoma, occult hepatocellular carcinoma among the nodules, which has to be very clearly identified. And coming to the CT, we see all the features on ultrasound as well as the selective left lobe hypertrophy and the right lobe atrophic features. Then we see surface nodularity, which is very well appreciated. We can see splenomegaly on CT very clearly, then moderate to massive ascites. And then we can also come across portal venous hypertension features and portal vein thrombosis, which are again vascular disorders. Coming to MRI, why is MRI important for those who are doing MRI abdomen? Now, as I said, among the nodules, there may be one or two hidden lesions, which are HCCs. So these small HCCs need to be clearly differentiated very early in the disease so that we can treat them adequately and manage the patient well. Now, what we see is that HCC has got an early wash-in and early wash-out, early enhancement and early wash-out, but this will not be seen in regenerative nodules as mentioned over here, because the regenerative nodules get their supply from the portal vein and the HCCs get their supply from the hepatic artery. Coming to masses. Now, hepatic masses are tumors of the liver. Again, they are broadly classified as in all tumors as benign and malignant. So in benign, we have got cavernous hemangioma, which is the most commonest. In malignant, the commonest one is hepatocellular carcinoma. And we also have metastasis, which can be solitary or multiple in the liver. So talking about hemangioma, a hemangioma is a clump of blood vessels, which is visualized in the liver. Hemangiomas can occur anywhere otherwise, but I'm talking about hemangiomas in the liver. So here what we see is a clump of blood vessels showing and a hyperechoic, well circumference lesion in most cases. These also can be small, large, and giant. Then the hemangiomas on ultrasound do not show any clear vascularity within, but peripherally it can show some feeder vessels. Coming to CT, as we see over here, the hemangioma over here is iso to hypodense on plane. When we do triple phase contrast, in the arterial phase, we see peripheral nodular enhancement, which has just started, as you are seeing here. Slowly, in the portal venous phase, the enhancement proceeds and occupies the rest of the lesion. And so, when we do the delayed phase, we see that the enhancement is almost the same as the rest of the liver. I mean, there's no outstanding lesion. The entire lesion and the remaining liver merge with each other. Coming to MRI, here, along with the features seen on CT, we have one special feature, that is that on delayed scans, the enhancement persists for a longer duration on MRI. Coming to hepatocellular carcinoma. Hepatocellular carcinoma is a concerning diagnosis because it is a cancer. Now, hepatocellular carcinoma, we can see of many types, that is a small, a large, and focal and diffuse. Here on my slide, what you are seeing is a hypoechoic, well-defined hypoechoic lesion. And this is different from the hyperechoic lesion which we saw previously. So most hepatocellular carcinomas are usually hypoechoic on ultrasound, though variations can exist in larger lesions. Now come to the CT scan. In the arterial phase, we see that since it is a cancer and it has got supply from the hepatic artery, it will show very quick enhancement in the arterial phase. And at the same time, the drainage of the contrast from the cancer lesion, from the tumor, will be exceptionally fast. So at the end of the venous phase, you will see hardly any contrast. Okay? So this is one of the hallmarks of a hepatocellular carcinoma. And on MRI also, you will be seeing similar findings, early wash-in and early wash-out. And the main important features when we consider hepatocellular carcinoma is the alpha-fetoprotein level, which is a very important blood marker for hepatocellular carcinoma. Please talk to your clinician when you're suspecting hepatocellular carcinoma and get the alpha-fetoprotein level. Now, I will be moving to the next part of the presentation, the gallbladder and the biliary tree. Here, we have the pathologies of the gallbladder and the biliary tree. In the gallbladder, the commonest are the calculus disease, inflammation, infection. Then we have got biliary strictures and masses under both biliary tree and the gallbladder. So talking about calculi. I'm sure all of you have seen gallbladder stones, and gallbladder stone is a bread and butter of a radiologist, and we come across it every alternate day or almost every day. Whenever we are looking for the gallbladder calculus, usually on X-ray, we see only 20% of the calculi because the remaining 80% are made of cholesterol, and we do not appreciate them on X-ray. So does not mean that calculi are not there, but the fact that we are not able to see them on X-ray. Now, what do we do next? Next we do if we suspect a patient with a right upper quadrant pain, if we see the gallstone on X-ray, whether we see it or we don't see it, we do proceed to ultrasound, which is the investigation of choice. And please make sure that when we do ultrasound, we tell the patient to be on overnight fasting on a low-fat diet, which will make us, will make the setting more favorable to look for a gallstone. Gallstones on ultrasound are seen as always hyperechoic nodular components within the lumen of the gallbladder. These can be single, multiple, and of small size or large size. Technically, usually a gallstone of up to 1 centimeter and less than, and only one in number, and not causing any problem, may be dealt with medical treatment. But if there are more than one gallstones, or if the size is more than 10 millimeters, and even a stone less than 10 millimeters causing any symptom, needs a surgical referral. Now coming to CT, here on CT what we see, depending on the component of the stone, here we are seeing cholesterol stone, so it is appearing black or hypointense. Here we are seeing calcific stones, so they are appearing brighter. And here it's a solitary stone, here there are multiple stones. So there is a, what we can say, a spectrum of visualization of calculi. And at times, even a gallbladder stone may not be seen on CT at all. So that does not mean that we are not reporting or we are not seeing the scan images properly, but that the stones are hiding. On MRI, invariably, all the time we see the stones in the form of filling defects on a very highly weighted T2 image, which is also the MRCP image sequence. Coming to the complications. Now, diagnosing a stone is not enough. A stone can cause problems in future, or a patient can come with problems due to a stone. Now, what problems can the stone cause? Here, we have got a calculous cholecystitis, that is inflammation of the gallbladder due to a stone and sludge around. Sludge is basically sedimentation of the bile. And here we are seeing a inflamed gallbladder on CT. Similar findings are reflected on the CT with some amount of very cholecystic fluid. On MRI again, we are seeing the same things. Now, cholecystitis, after the calculous cholecystitis, again, some patients may seek treatment, some patients may just take a visit to a single visit with a doctor and stay back. So some patients who neglect cholecystitis and acute cholecystitis symptoms may develop complications. In complications, what we see are sometimes there can be gas within the gallbladder or the walls of the gallbladder, which is known as a emphysematous gallbladder. These are the images over here, the gas in the CT clearly visualized. Or a gangrene can develop within the gallbladder, where we see the membrane within the gallbladder lumen. You can see the irregular membrane over here. And this differential diagnosis of membranes in the gallbladder is ascariasis in the gallbladder, which is again a totally different condition. On CT and MR again, we make a diagnosis of membranes within the gallbladder and irregularity and additional inflammatory changes and abscess type of formation. Now coming to perforation of the gallbladder, which is a bursting of the gallbladder due to continuing inflammation. The wall of the gallbladder breaks and causes bursting and release of the calculus within the abdominal cavity. At times, the gallbladder, the burst area or the perforated area can adhere to the bowel, and a continuous fistulous communication can be formed, and then the stone gets released within the bowel over here, and this is known as a gallstone ileus. Coming to other gallstone pathology, gallbladder pathologies, we can see the xanthogranuloma cholecystitis. Again, this is a continuous low-grade inflammation of the gallbladder and containing calculi, which forms cholesterol-containing hypoechoic areas or hypodense areas on CT, hypoechoic on ultrasound, and hypodense over here. This is again a benign condition and needs to be differentiated from other malignant conditions. And then here, what we are seeing is the porcelain gallbladder, wherein there is calcification Zinn type of the complete gallbladder. And this surprisingly is a pre-malignant condition. So the record has to be made, it has to be followed up by subsequent imaging, and the patient has to meet a surgeon at the earliest. Coming to polyps. Polyps are finger-like projections of the gallbladder, and these may be of variable sizes and these protrude within the lumen of the gallbladder. A polyp that is less than 10 millimeters is usually harmless, and most polyps I have encountered are usually 4 mm, 5 mm, 6 mm. Rarely we can encounter polyps which are around 10 mm or more. The polyps which are 10 mm or more, they are again pre-malignant and predisposed to cancer of the gallbladder. And one thing to be noted is that the gallbladder polyp will not move, whereas the calculi and other the calculi in the gallbladder will be mobile in most cases, but the gallbladder polyp will not move, and it is also again in the non-dependent position. It can be very well visualized. Now coming to the other feature of other condition of the gallbladder, which is again a benign condition. This is the adenomyomatosis of the gallbladder. Here what happens is cholesterol crystals get impacted on the wall, luminal wall of the gallbladder, and it shows artifacts of comet tail type and on ultrasound. And on CT, the similar appearance we can see like that of a pearl necklace over here, beads. Coming to gallbladder carcinoma, again, as we all know, any cancer is a concern. So gallbladder carcinoma, like other carcinomas, are uncontrolled infiltrating proliferative growths of the wall of the gallbladder, and it can infiltrate into surrounding structures. What we see here are coexisting associated gallstones, and a gallbladder cancer may have or may not have stones, and the stones really do not matter to the formation of a gallbladder, but might be due to the continuous sedimentation of the bile due to the diseased gallbladder. Now coming to choledochal cysts or bile duct, choledochal calculus or bile duct calculus. Here there are calculus obstructing the distal part of the bile duct, which is the part of the biliary tree after the formation of the bile duct, that is after joining of the common hepatic duct and the cystic duct, which I'm sure all of you are aware of. So in ultrasound, the bile duct calculus will be seen as a rounded filling defect and causing dilatation of the bile duct to about by about 6 to 10 mm, and that is a natural hold up of the bile proximally and dilatation of the proximal biliary tree and jaundice features. So here what we are seeing is a radiodense bile duct calculus in the distal bile duct, but all calculi are again not radiodense. So we may not see all calculi on CBD calculi on CT, and we will be appreciating the proximal biliary dilatation on CT, which is very visualized. MRCP is the investigation of choice, and we see the filling defects as well as the entire biliary tree is very well visualized on MRCP images. Coming to cholangiocarcinoma, this is a cancer of the biliary tree, and the biliary tree again has smaller, as any tree, the smaller branches, that is the smaller biliary ducts, then slightly bigger ones, and the main ones. So here we are seeing the peripheral biliary infiltrating type of cancer, which is a mass forming. Here there is retraction of the liver capsule, and this is the mass. There is not much of biliary dilatation because it is totally in the periphery. Here we are seeing a cholangiocarcinoma of the intraductal type, where is part of a large duct is involved, and we are seeing the tree distal to it is all dilated. And this is the pathological specimen. Here, this is a classical tumor of the hilar cholangiocarcinoma, which is obstructing at the level of the junction of the bilateral main hepatic ducts, the right and the left, and the common hepatic duct. And this will be causing a dilation of the entire proximal biliary tree and severe jaundice. And by most of the time, when the diagnosis is made, it is already an advanced stage, and patient needs immediate palliative treatment. So with this, I conclude the walkthrough of the pictorial review of the hepatic and the biliary system. And I'm sure this is not enough. You may be having some questions, some doubts, and certain clarifications to make. May I request you to please post them on the chat box, and we will answer them back shortly. With this, I hand over the discussion to my director, Dr. Karthik Gopal sir. Thank you everyone for the hearing.
Super. Thanks, Vivek. Thank you very much for the wonderful presentation.